6 months, and if you compare that to what we had initially, a very nice result. And if you compare that to the contralateral side, our control connective tissue versus the PDGF, very similar results, and without the donor side. So what were our objective measurements? The things that are highlighted were the only differences statistically between the two procedures. And if we look at root coverage again, you see very similar results to what we had last time. About 89% root coverage with our connective tissue grafts, so we're overperforming what you would expect from the systematic reviews there. But if you look at our root coverage with our PDGF, about 91%. So again, Vince marked that like I said, you would expect 89% with a connective tissue graft. We're doing very well with our coronally advanced flap with the PDGF. How about connective tissue graft versus coronally advanced flap with an enamel matrix derivative? A study we did a number of years ago. Again, it's very same primary and secondary efficacy parameters. The only difference with this study is that the defects are bigger. To get into this study, you had to have at least 4mm defects, so these are going to be wider and deeper defects, probably a little more difficult to treat because of that. This will be our control. You'll see this particular patient has a fair amount of root surface abrasion. Here I'm placing the connective tissue graft in there, coronally advanced the flap, and at 1 year, very nice 100% root coverage. Same patient, opposite side. This will be our test site. Again, a wide, deep recession. Again, note the amount of root surface abrasion we have, almost 2mm. Now, a moment ago when I put that connective tissue graft into that abraded root surface, it's almost like an inlay into an inlay prep, isn't it? What's going to happen when I put this viscous enamel matrix derivative? Is the flap going to collapse onto the root surface? Are we going to have an improper emergence profile? Here's what we have at a year, 100% root coverage, and if we look at our emergence profile, no, it supported that even though we had a significant amount of root surface abrasion, and that's the trend we saw in the study. How about our objective endpoints? We achieved 95% root coverage with our coronally advanced flap with EMD versus 94% with our connective tissue. So we didn't do quite as well with the connective tissue, probably because they're a little bigger defects, but to my knowledge, this is the only RCT that's published where connective tissue graft is a control where the test was not statistically significantly different. Where it was different is look at percent root coverage. We achieved complete root coverage 79% of the time with connective tissue graft, and we achieved complete root coverage with EMD 90% of the time. So that was a significant difference between the two. Now, arguably, you can cover root surfaces with anything. What separates the men from the boys is what type of attachment do you have there. So let's look at a few studies that we've done looking at the type of attachment that we're gaining. This is a study we published a few years ago that I just showed the outcomes of, where we're going to compare connective tissue to coronally advanced flap with PDGF, and Professor Schubach did fabulous histology on this. So we have a model that allows us to very ethically get human histology, IRB approved. We look for adult patients needing orthodontic therapy with bicuspid extractions. So in this particular study, we had 2 patients. One needed 2 bicuspids extracted, the other needed 4 bicuspids extracted. Each patient was randomized to receive 1 connective tissue graft, and the other grafts were going to be coronally advanced flap with PDGF. And what do you see? Well, we achieved 100% root coverage with everything. No surprise. But what was different was our connective tissue grafts showed no regeneration, and all of our PDGF grafts demonstrated regeneration. So here's an example of one of our PDGF grafts. Here is our recession. I've marked at the recession gingival margin with high-speed finishing burr. I've marked at the alveolar crest. I've grafted it with PDGF. Here is the tooth removed in block at 9 months after the graft. You see we have 100% root coverage. But what does it look like under that? Under that, if you look at the micro-CT, we see we have bone growing all the way up to the notch at the original free gingival margin. You can't see this, of course, because the bone's grown up over it. Nice even space for the PDL. Look great. You know, I always want more, so I say, that looks good, but why didn't we get more? And what I'm going to tell you is not in our original manuscript, because I didn't understand this until I'd actually lectured about it a number of times. Now we know this is 3mm from the CEJ. What occupies that space? What's 3mm from the CEJ? Biologic width, right? you have to have the biologic width. So we generated bone to the limits of the biologic width. Here is a micro-CT that Professor Schuppach sliced right through that. It's so beautiful, it looks like an illustration, but it's actually the slice right through there. So here we see 100% root coverage, or sulcus, long junctional epithelium, connective tissue attachment, our biologic width, our newly regenerated bone. And if we look at this area, what do we have? You know, you don't have to squint your eyes here. We have old cementum covered by new cementum, Sharpie's fibers, new bone, Sharpie's fibers, functionally oriented PDL. Beautiful regeneration over the root surface. And we're not talking about just a little regeneration. Again, if you go to the literature and you look at everything out there that shows regeneration on root surfaces in humans that report regeneration, they usually report, yes, I got it, or no, I didn't. They don't talk about how much. Those that talk about how much, it's usually in the 0.5 millimeter range. Note, we're regenerating 2 to 3 millimeters of bone over the root surfaces, enough that's not only highly significant, but clinically significant as well. Compare that to the same patient to the control. Here's our 2 histologic markers. I grafted with connective tissue, and yes, we achieved 100% root coverage. But what do we see here? When we look at it, we can see our notch at the alveolar crest, because we got no regeneration. We've got a long junctional epithelium, connective tissue attachment. That's what we expect with a connective tissue graft. This is a study that we just completed that we haven't published yet. It's in the final stages of manuscript preparation. This will be the largest study ever published looking at human histology on root surfaces. Again, the same model that I just showed you, except this time we're going to use coronally advanced flap with enamel matrix derivative. We've got 3 teeth with our connective tissue, our control, 100% root coverage, but you don't see any regeneration here, do you? You see the long junctional epithelium, connective tissue attachment running up the root surface, no regeneration with our connective tissue. Very different story with our enamel matrix derivative. We have 7 out of 9 of our teeth with an enamel matrix derivative exhibiting regeneration, this being our best case. If you look here, we have 100% root coverage. We've got our sulcus, our long junctional epithelium running to the CEJ. As we move down the root surface, we have our connective tissue attachment. And as we move further down the root surface, you see our newly generated osseous crest. And we generated that all the way up to the notch at the gingival margin. So again, we achieved as much regeneration here as is biologically possible. If you look at the polarized light microscopy, you see functionally oriented PDLs going into the new bone. Well, what happens as we move down the root surface? We see a nice even space for the PDL, we see our new bone, and as we go further down the root surface, here's our notch at the original alveolar crest. We have new bone spanning that, and if we go further down, we see the old bone and then the new bone going up over it. And if we look at our micro-CT of that, we see that we have bone going all the way to the notch of the original gingival margin, again, achieving as much generation as is biologically possible on this root surface. So we conclude that, yes, enamel matrix derivative does promote root coverage, it promotes regeneration in a very different way than connective tissue graft, and we hope to have this published fairly soon. Well, how about stability? Again, very important. The European Workshop of Periodontology suggests that we probably want to wait 5 years to really look at materials before we can understand them, because everything looks good early on. And we follow all of our studies long term, where this paper's in preparation for manuscript. This is the 5-year results of the root coverage study I showed you with the xenogenic collagen matrix. And I always try to use the same patients that were in the original publication for photographs, so you can't accuse us for cherry picking, just picking the best patients. Here's the same patient who's at a year, here they're at 5 years, beautiful results. And if we look at our objective measurements, at 6 months and 5-year root coverages, the changes were not statistically different between the different therapies. How about with PDGF? We published this last year. And again, if you look at the clinical images from our original manuscript of 5 years, very pretty results with our PDGF, very nice results with the connective tissue, and our objective measurements, again, no significant difference between baseline and 5 years. Well, how about even longer periods of time? We looked at our study that we did looking at chronally advanced flap with enamel matrix derivative at 10 years. Remember this patient I just showed you. Well, here he is at 10 years. This is at 1 year. At 10 years, connective tissue graft maintaining quite well. I'd like to tell you this is chlorhexidine stain. This is just stain. This guy has not been to the dentist since I saw him 10 years ago. He only came in because we were going to offer him a free cleaning and such. So this is results with no maintenance whatsoever. And remember, this is the one that I was worried about, the tissue collapsing. Well, here he is at 1 year. Look at 10 years. 100% root coverage, clear increase in keratinized tissue, and yes, we're maintaining the emergence profile. So our results at 10 years after initial surgeries were the same, whether you treated it with connective tissue graft or EMD. And if we look at the outcome measures, the EMD dropped from 94% at 12 months to 83% at 10 years. That's well above what you would expect at 6 months on the mean of the systematic reviews. And if you compare that to the only study out there comparing anything at 10 years is the nickel study, using the polylactic acid membrane, and they had abysmal results at 10 years. 5 out of 9 of their GTRs were actually worse than they were at baseline. So it kind of goes against doctor do no harm. Well, let's end with looking at papilla regeneration. What do we know about the evidence with that? Well, we know there's not much evidence, right? Again, we've got a few case reports, maybe 1 or 2 case series, very small. This is the only RCT, to my knowledge, that's been published on papilla regeneration. Because we're not successful as a normal role with traditional therapy, we wanted to look at this in a novel approach. So we harvested some of our patients' tissue from the palate. We sent it to the laboratory. We grew out different cell strains. We took the fibroblasts. We grew the fibroblasts out to 200 billion fibroblasts per ml, put it into an injectable medium. We surgically altered or wounded the papilla to cause swelling, and we injected that. Now, we're not injecting a filler here. We're injecting the patient's own living fibroblasts that are capable of producing collagen. And the study had 20 patients, a total of 118 sites, with 40 matched and randomized control and test sites. Our primary endpoint was looking at the papilla height to the contact point, but we also looked at papilla height to the osseous crest, and we measured it in a variety of ways, with our most sensitive being standardized digital photography. And we also did a number of different safety measurements. Now, all of you have injected local anesthetic papillas. You know you can't expand them in that way. So we had to develop what we call the papilla priming procedure, which is just a surgical wound. We're going to go in. At 3 days, you see a little swelling. At 7 days, it's still swollen, but less acute. And if you leave it alone, it all goes back to normal. But looking at wound healing, what's really going on with that? Well, as soon as you do the papilla priming procedure, you begin the phases of wound repair. Plasma proteins, primarily fibrinogen, comes onto the wound surface. You begin the early phase of the inflammatory phase. Neutrophils are flooding in. Fibroblasts are beginning to upregulate. They're starting to produce collagen. And in about 1 to 2 days, you then move into the late stage of the inflammatory phase. The neutrophils are being replaced by monocytes and macrophages. The fibroblasts, at about 5 days, the body says, okay, gang, that's enough. We're going to shut you down. Collagen accumulation begins to wane, and you enter the granulation tissue formation phase. Now, some people think it's the granulation tissue formation phase that will determine how much tissue you have at the end. If you have a short granulation tissue formation phase, you could end up with a net loss of tissue. If you have a long granulation tissue formation phase, you could actually increase the amount of tissue. So that's going to be our experimental concept. We're going to say, okay, when the body shuts down its own production of fibroblasts, we're going to come in at 7, 14, and 21 days and inject more fibroblasts, which are going to produce more collagen, hopefully going to increase the amount of tissue that we have here. So we're measuring this with standardized digital photography. Easier to look at the plot here. The y-axis is the open interproximal space, and this is time. So this is our papilla priming. Note that the open interproximal space closes. Why? Swelling. And then it's this first injection, second injection, third injection. If I was just injecting a filler, that's all we would get, which is not much. But look what happens. It continues to close down, even though I've not injected any more. How's that possible? I didn't make any more injections. Well, it's possible because the fibroblasts are continuing to produce collagen, thickening the dermis, closing the space. So I'd like for you to look at this open interproximal space here. I'm going to show you a time lapse over 4 months after 3 injections. And I haven't changed this as far as computer. You can do anything with a computer. But just take a look at what happens here over 4 months. Well, we now know that it's possible. If we find this predictable, I'll be opening papilla parlors all over Europe next year. And our objective results were that autologous fibroblasts are safe and might be used to treat open interproximal spaces. Our patient-reported outcomes were highly in favor of this. Both the patient and the blinded examiner felt this worked very well. Our objective endpoints failed to support that, primarily because of numbers and lack of sensitivity of measurements. Well, what type of tissue are we generating? Well, what we find is 6 months, very site-appropriate tissue. We have no more inflammation, just more fibroblasts, thicker dermis. And how about stability? Well, here's our patient at day 0, and here I am injecting into that papilla. Again, I'm not injecting collagen, I'm injecting fibroblasts. We're injecting about 6 to 8 million fibroblasts into this papilla. Here it is at 4 months. At least I can see a clear difference here. How about longer? What happens over time? Here's that same patient at 5 years. No more injections. Just this dynamic protein delivery system continues to produce collagen, closing down the furcation. So let's conclude. What are our evidence-based alternatives that we've been looking at? Well, if we look at keratin increasing keratinized tissue, free gingival graft, our gold standard. Very positive clinical outcomes. Negative patient-related outcomes, though. Site-appropriate tissue, yes. Stability, you can take it to the bank. How about xenogenic collagen matrix? Positive clinical outcomes. Positive patient-related outcomes. Create site-appropriate tissue stability? We don't know yet. It appears, though, it should be stable. How about alternatives to root coverage? Our gold standard, connective tissue graft. Positive clinical outcomes. Negative patient-related outcomes. Generally, you don't expect regeneration. Very stable over time. Xenogenic collagen matrix, positive clinical outcomes, positive patient-related outcomes. Study hasn't been done yet. We don't know what kind of attachment we get. Probably not regeneration, but we don't know until it's looked at. And appears to be stable over time, at least out to 5 years. And PDGF, clinical outcomes positive, patient-related outcomes positive, does create periodontal regeneration, stable out to at least 5 years. EMD, positive clinical outcomes, positive patient-related outcomes, will create regeneration on root surfaces, and we know it's stable out to at least 10 years. How about papilla augmentation? Very limited information, or hard to even find a gold standard, but you have to say it's connective tissue. Generally negative clinical outcomes, generally negative patient-related outcomes. When you are successful, you do get site-appropriate tissue, and stability so-so. Very limited information with one RCT, but with our fibroblasts, kind of positive, negative clinical outcomes. We had very positive patient-related outcomes, though. And we created site-appropriate tissue. Not only did it appear to be stable over time, but it appears to improve over time. So, what's the answer? What material should we use? Do we look at all the grids I just gave you, count up the number of positives, and whoever has the most positives wins? It'd be nice if it worked that way, but it doesn't work that way, does it? Because our patient brings us factors we have to look at. The defect brings us factors we have to look at. And your surgical experience and your access to these materials have to factor in as well. It would be naive to think that any one material is going to work best in all defects in every individual. So we have to factor all of this in order to provide the best treatment. And with that, I thank you very much. It's been my pleasure to share a few ideas with you this morning.